Good morning, everybody, and welcome from Canada. Thank you so much for turning into this international webinar sponsored by the International Menopause Society on what to offer for vasomotor symptoms when menopausal hormone therapy is contraindicated. We have two wonderful speakers today, my esteemed colleagues Susan Davis and Nick Panay. And Susan will be speaking on non-hormonal prescription medicines for vasomotor symptoms. Are they effective? And Nick will be speaking on complementary therapies for vasomotor symptoms. What is the evidence for efficacy and safety? I'd like to thank Besson's for providing an unrestricted educational grant from Besson's Healthcare. It had no role in the selection of topics, selection of speakers, and they have not reviewed the content of the speakers' presentations. So we're going to begin now. And if you have questions and answers, you can put them in the Q&A box during the sessions. So I'm thrilled to introduce my colleague and friend, Professor Susan Davis. She's an NHMRC Senior Principal Research Fellow, Director, Monash University Women's Health Research Program, Consultant Endocrinologist and Head, Specialist Women's Health Clinic for Women with Complex Disease, Alfred Hospital, Melbourne, and Consultant at Cabrini Medical Center. Her research is known worldwide, and she's advanced the understanding of estrogen and testosterone action, deficiency, and replacement in women. She is past president of the International Menopause Society, past president of the Australasian Menopause Society, and a fellow of the Australian Academy of Health and Medical Sciences. She has over 430 peer-reviewed publications, and her contributions to endocrinology were recognized by the International Excellence in Endocrinology Laureate Award of the Endocrine Society USA in 2015, and the Australian Endocrine Society Senior Plenary Award in 2019. Thank you, Susan.
Good morning, good evening, good afternoon, everybody. And Wendy, thank you for that very generous introduction. And I've been tasked with talking to you about non-hormonal prescription therapy for vasomotor symptoms when we feel that HRT is contraindicated. So here are my disclosures. I will not be presenting any of my own original research in this presentation, and most of my academic research funding is from competitive grants. So postmenopausal vasomotor symptoms, as you all know from this audience, are very common. They affect a large proportion of women globally, not just in developed countries. Women who experience vasomotor symptoms experience often concurrently low mood and low well-being, anxiety and poor work performance. And the physiology of vasomotor symptoms, although we have hypotheses, still remain poorly understood. And that's really limited our progress in non-hormonal therapies. So we know that there are some absolute contraindications to menopausal hormone therapy, such as undiagnosed vaginal bleeding, hormone-dependent cancers, recent stroke or TIA, and other estrogen-sensitive tumors other than breast and endometrium. And generally, we would consider porphyria cutanea tarda a contraindication. We have relative contraindications. The ones in the lighter orange are ones that are predominantly for oral estrogen, and we would often use a transdermal estrogen in these relative contraindications. And in the red, we have concerns about women at high risk of breast cancer and so forth is listed there. So there is a need for having therapies that we can use that are not estrogens to treat women with really bothersome symptoms. So what do we have in our toolkit? Well, I've listed these here. They'd be familiar to most of you. and I'm going to go through these. They're different formulations and different compounds are available in different countries, but I hope to just briefly go through the evidence for the use of these and their potential side effects. So clonidine's been around for a long time. When I first trained, it was the only non-hormonal therapy we used. Women complained of dry mouth. Most women didn't find it very useful. And now this is a meta-analysis published in 2006 of the trials that have looked at clonidine for the treatment of vasomotor symptoms. And you'll note that very few trials were identified and only 3 were deemed to be of fair quality. And four of these total studies reported reduced vasomotor symptoms compared to the comparator therapy or control. And the mean difference in the number of hot flushes per day really was quite modest. So there may be a therapeutic benefit, but it is really very mild. Subsequently, historically, the SSRIs were used for or introduced for the treatment of vasomotor symptoms. And one of the first studies done was this study of Liprinzi and colleagues published in the Lancet in 2000, looking at 3 different doses of venlafaxine. The study was actually over 8 weeks, but they reported the data for over 4 weeks. Women were included if they had a history of breast cancer or reluctant to take menopausal hormone therapy because of fear of breast cancer. Over 2/3 were on tamoxifen, and the baseline number of vasomotor symptoms was 8 per day. And you can see that there was a reasonable proportional reduction in vasomotor symptoms compared to placebo, with really no benefit of 150 milligrams over 75 milligrams. But it is noteworthy that it was of short duration and the number of women included in each treatment group was small. In fact, for the majority of the studies I'm going to show you, the number per treatment group is small. This is a study of data for paroxetine, again, only approximately 50 in each treatment arm. This had an inclusion requirement of women to have at least 2 to 3 hot flashes per day. Interesting, it wasn't 2 or wasn't 3 as a cutoff, it was 2 or 3 or more. And in this study, there appeared to be a benefit at 6 weeks of 12.5 milligrams and 25 milligrams over placebo. Sertraline has also been studied, and this showed a modest effect at 50 milligrams per day. This study was a double-blind crossover trial of just under 100 women aged 40 to 65, and they had to have baseline, they had on average 46 hot flashes per week, but as few as 2 and as many as 148. And you can see that compared to getting placebo first, the women who got sertraline first had a much greater reduction in vasomotor symptoms. You can see that it plateaued out after the washout, and then the women who got sertraline second, this group, had a significant improvement, but you can see a really big placebo response as well. So this study really shows the problem of high placebo responsiveness in short duration trials. So this is a meta-analysis done by Nelson and colleagues published in JAMA in 2006, looking at the studies of SSRIs and SNRIs together. And you can see that there were 4 trials of women with breast cancer plus a SERM that reported a decrease in vasomotor symptoms. The 2 trials highlighted with the red asterisks were of women without breast cancer, and they did, or a SERM, did not show a benefit. So the benefit was really limited to the studies that include SERMs, and overall there was a trend towards a benefit, a statistical benefit with SERMs, with SSRIs or SNRIs versus placebo for vasomotor symptoms. The most consistent effect was seen with paroxetine. And this study looked at combining zolpidem with venlafaxine for menopausal symptoms, particularly looking at sleep outcomes, because as we all know, women complained complain tremendously about poor sleep quality after menopause. And not surprisingly, more women augmented with zolpidem than placebo were responders on the sleep outcome. Interestingly, the reduction in hot flashes did not predict improvement in sleep, and about 60% in each group had adverse events. Overall, the adverse events were very minimal, and the sleep improvement was good, but I don't think any of us would recommend long-term zolpidem for sleep deprivation as a good therapeutic long-term option. So how do all these stack up against estradiol? Well, you can see in these, this is vasomotor frequency on the left and bother on the right, and the blue is estradiol therapy, but please note that's estradiol at the dose of 0.5 milligrams per day, and very few of us would prescribe such a low oral dose to patients. And you can see that escitalopram and venlafaxine were reasonably good compared to low-dose estradiol in terms of frequency. Other interventions in the Miss-Flash series of studies did not show significant benefit compared to these particular therapies. So this reinforces that venlafaxine and escitalopram can be considered for vasomotor symptoms in women. We know that tamoxifen is converted to endoxifen by P450 enzymes in the liver, and that some SSRIs inhibit this process. And although venlafaxine only has a slight effect, paroxetine can substantially influence the activation of tamoxifen, and we would consider it contraindicated in women on tamoxifen because it could inhibit the efficacy of tamoxifen. So the next compound that gained interest was gabapentin. So gabapentin is a GABA analog that primarily was used for the treatment initially of epilepsy and neurogenic pain, and it's still one of the major uses, as well as treatment of restless leg syndrome, tremor, and it's used for bipolar disorder and migraine prophylaxis. It has a very wide therapeutic index so that some patients will actually need quite a high dose to get efficacy if efficacy is going to be achieved. It's not metabolized by the liver, but is excreted by the kidneys. One of the problems is withdrawal. So if a patient is on high dose therapy and wants to cease the therapy, they can get some substantial withdrawal symptoms that mimic alcohol and benzodiazepine withdrawal. So dose reduction for withdrawal has to be considered slowly. And compared to placebo, this was an important study in the Lancet, there was a significant benefit of gabapentin taken at night, with the most efficacy seen with the 900 milligram dose for hot flash frequency and severity, but many women will respond to 300 milligrams or even 600 milligrams at night. And this is a study of women with breast cancer. Now, I've divided this up. This is the different studies looking at the duration of treatment, 1 month, 3 months, 6 months. You can see 1 month, 2 month, 1 month, 2 month outcomes at different doses, etc. Looking at the vasomotor frequency over time, and you can see that there is a benefit of gabapentin over control. There was an effect of side effects of dizziness and somnolence, so the two side effects. That's why we generally recommend this is taken at night. And this shows you a duration effect, studies after 12 weeks and after 24 weeks. And again, there seems to be a fairly good benefit of gabapentin over placebo in terms of vasomotor symptoms for women. Oxybutynin is the most recent compound that is available on prescription therapy that is being used to treat vasomotor symptoms. It is an anticholinergic that you would be very familiar with to treat overactive bladder, usually 5 milligrams 3 times a day. And the common side effects are dry mouth, drowsiness, and blurred vision. And this study was 12-week double-blind randomized placebo-controlled trial, looking again at vasomotor symptoms, severity and frequency, oxybutynin compared to placebo. And 50% of the women in the oxybutynin group had dry mouth, and there was about a 7% discontinuation rate with the oxybutynin because of this major side effect. And again, this was 15 milligrams daily. Subsequently, there's been a study looking at low dose, 2.5 or 5 milligrams of oxybutynin daily, and actually showed fairly good efficacy compared to placebo therapy on the percentage change. This is the percentage change in hot flush score. So you see a 77% decrease with 5 milligrams twice daily, and a fairly similar decrease with 2.5 milligrams twice daily. And this was given in a liquid form. It was a 6-week study. This shows you the adverse events. The main adverse event in this study compared to placebo was dry mouth in 33% of the women who had the 5 milligram BD dose and 21% on 2.5 milligram. This was the only side effect that was different to placebo. So many women will tolerate this as a side effect, although the discontinuation rate because of the side effects was still 10%. Now, although this is not a non-hormonal therapy, it is a prescription therapy for treatment of vasomotor symptoms. So I've sort of thrown it into the mix, and that is the use of progesterone for vasomotor symptoms. There's not a lot of high quality data for this, and this is one study published in 2012 that looked at 300 milligrams at night compared to placebo for vasomotor symptoms in women aged 44 to 62. And basically, even at this high dose, progesterone was not effective compared to placebo in reducing vasomotor symptoms significantly. People have looked at transdermal progesterone, and most studies show inadequate serum levels with transdermal preparation and no benefit for vasomotor symptoms. So we would not generally recommend this for women, and most women will not really tolerate a very high dose in order to get efficacy. Now, I know Nick's going to talk about exercise, but I threw it in as well, basically because I think this is one of the few non-hormonal, non-prescription interventions patients are likely to think their doctors might know something about. Patients don't tend to ask us about yoga and meditation, but they often ask us about exercise. And this was a study looking at the effect of resistance training on vasomotor symptoms, and 65 women were randomized, 29 per group completed, and there was a modest effect of resistant training on vasomotor symptoms. But overall, there is evidence from other studies that moderate intensive aerobic exercise, the first was resistance training, this is aerobic exercise, does not alleviate vasomotor symptoms, but may actually make women feel better. Now, I'm not going to talk about neurokinin receptor antagonists for two reasons. One, these are not yet available for routine clinical practice. These are still being researched. These include the NK3 receptor antagonists and the dual neurokinin 1 and 3 antagonist. And there is going to be a webinar specifically addressing how these compounds work, act, and their future likelihood of usefulness in the clinic next month. So that's a reason for me not to talk about it, and also a quick advertisement for you to tune in again in a few weeks' time. So in conclusion, the alleviation of moderate to severe vasomotor symptoms without estrogen remains a real challenge. And many of us will have patients who have severe symptoms, and we go through our armamentarium of different options, and in the end, the poor patient's still suffering severe symptoms. And it's heartbreaking for the patients and also heartbreaking for us as doctors. And that's because the current therapies do provide insufficient relief for many women. We have the neurokinin B antagonists in the pipeline and they hold promise. And I commend the next webinar to you. The other thing is that we all know estrogen acts on a diverse array of consequences of the menopause, not just hot flushes and night sweats, but vaginal dryness and bone loss, etc. And we don't have a poly pill that matches up to estrogen. And yet when we're treating hot flushes with these non-hormonal therapies, it's important to think about all the other things we need to consider, such as bone health and mental health. And when not contraindicated, estrogen still remains the optimal pharmacotherapy to alleviate the full spectrum of symptoms.
Thank you, Sue. Now it's my pleasure to present my colleague and friend, Professor Nick Panay. And unfortunately, he's acquired a bit of laryngitis this morning. And so Dr. Davis has very graciously said she will help out if his voice gives out. So thank you for your patience, everybody. So Nick is going to be speaking, we hope, on complementary therapies for vasomotor symptoms. What is the evidence for efficacy and safety? Nick is a consultant gynecologist with a special interest in reproductive medicine and surgery, menopause, PMS, contraception, and gynecologic endocrinology. He's director of the West London Menopause and PMS Center at Queen Charlotte's and Chelsea and Westminster Hospital. He heads a busy clinical and research team which publishes widely, presents at scientific meetings, and trains health professionals at all levels. Much of his team's research has focused on improving the understanding and management of premature menopause, and he's world-renowned for this. PMS, female sexual dysfunction, new hormone replacement therapies, contraceptive regimens, and complementary therapies. He was the co-editor-in-chief of Climacteric and is on the editorial advisory board of Journal of Family Planning and Reproductive Healthcare. He's also currently president-elect of the International Menopause Society, the past honorary director of conferences for the Royal College of Obstetricians and Gynecologists, past chairman of the British Medical Society, chairman of the National Association for Premenstrual Syndrome, patron of the DAISY Network for women with premature menopause, and past council member of British Society for Gynecologic Endoscopy. So welcome, Nick, and I hope your voice holds out. And thank you, everyone.
Thank you, Wendy, for that kind introduction. And I hope that the voice does hold up. And thank you to Sue, who has offered to step in if required. I'd like to thank IMS for the invitation to give this presentation, particularly Steve Goldstein. So in the next 20 minutes, I will review the evidence for the efficacy and safety of complementary and alternative therapies for menopause-related symptoms. And these are my disclosures. At the end of this lecture, I hope you will be able to understand the complementary and alternative therapy options for management of menopause and familiarize yourself with the available evidence on the efficacy and safety of these preparations. And the slides are mainly derived from the IMS IMPART educational program, which is free to register at the IMS website. Let's proceed to the first section, which covers complementary and alternative therapies for menopause. So why would MHT not be appropriate for all women? Well, women should always have a choice. There may be a medical contraindication, such as a hormone receptor positive malignancy. It may be that genuinely an alternative may be better for the woman, or she may be scared to use MHT because of the adverse media headlines that there had been. Complementary and alternative medicine, which I'll call CAM, is a group of diverse medical and healthcare systems, practices, and products that are not presently considered to be part of conventional medicine. So when describing these approaches, people often use alternative and complementary interchangeably. The two terms actually refer to different concepts. Complementary medicine is a non-mainstream practice used together with conventional medicine, while alternative medicine is a non-mainstream practice used in place of conventional medicine. So the categories of CAM include plant-derived products, complementary and alternative medicine practices, and other miscellaneous medicines. Plant-derived products include phytoestrogens, herbs, and vitamins and minerals. And the phytoestrogens include soy, red clover, and flax seeds. The herbs include black cohosh, dong quai, and other plant-derived products, such as evening primrose, St. John's wort, ginkgo, ginseng, and hops. And vitamins commonly include vitamin E. The next category of CAM includes mind-body practices, such as acupuncture, massage therapy, yoga and meditation, relaxation techniques, chiropractics, osteopathy, spinal manipulation, CBT, mindfulness, meditation and relaxation, and movement therapies. Other complementary therapies include homeopathy, naturopathy, and Ayurvedic medicine. Homeopathy is a system of complementary medicine in which ailments are treated by minute doses of natural substances that in larger amounts would produce symptoms of the ailment. Naturopathy is a system of alternative medicine based on the theory that diseases can be successfully treated or prevented without the use of drugs by techniques such as control of diet, exercise, and massage. And Ayurveda is based on the idea of balance in bodily systems and uses diet, herbal treatment, and yogic breathing. Two systematic reviews on the use of CAM for menopause symptoms have been published. The first was conducted in 2013. 11 databases were searched for peer-reviewed surveys to estimate the use and pattern of CAM amongst middle-aged women. The review suggested that 33% of women were current CAM users, 50.5% of women use CAM specifically for menopause symptoms. The average use of CAM over a period of 12 months was nearly 48%, and almost 55% of women did not disclose their use of CAM to their healthcare professional. So this is very, very common practice, more common than we think. The most popular CAM modality was herbal medicine, followed by soy phytoestrogens, evening primrose, relaxation, and yoga. In another systematic review conducted by Peng, they performed a comprehensive search for peer-reviewed articles from 4 databases. The review suggested that the prevalence of CAM use ranged from 31 to 82.5%. The prevalence of menopausal women who use 1 or 2 CAM products daily ranged from 15 to 90%. There was incredible variation in the research findings. Vitamins and minerals were the most commonly used CAM, followed by herbal remedies, relaxation techniques, or yoga. And the prevalence of combined use of MHT and CAM ranged from 12% to 46%. A study was undertaken to document the prevalence and factors associated with the use of CAM for vasomotor symptoms and other symptoms of the menopause in Australian women aged 40 to 65. Of the 2020 participants, most were postmenopausal. The prevalence of use of any CAM for VMS was around 13%. Phytoestrogens were most commonly used for VMS, followed by evening primrose oil and ginseng. Overall, 8.3% of women reported having at least one consultation with a CAM practitioner. More educated women were most likely to have consulted a CAM practitioner. In the UK, a large cohort of postmenopausal women participating in the collaborative trial of ovarian cancer screening were followed up with a questionnaire on the use of CAMs and non-pharmacological interventions for menopausal symptom relief. The cohort included over 88,000 women with a mean age of just under 65 years. The study suggested that 1 in 4 postmenopausal women in the UK reported ever use of CAM or non-pharmaceutical options for the relief of menopause symptoms. The highest use was reported for herbal remedies, with a prevalence rate of just under 44%, followed by vitamins, lifestyle approaches, and phytoestrogens. The ever use of herbal therapies, vitamins, and phytoestrogens was less in older women. And Black ethnicity, menopause hormone therapy, or previous oral contraceptive use were associated with an increased use of CAM and NPIs. So let's summarize some of the most important points from this section. The use of CAM for disease management is common. Many women use CAM to relieve menopause symptoms, often before they will consider MHT. Women often feel that they did not need to inform their doctor about CAM use, so it's important that we inquire. And it's important that if women are having a consultation with a CAM practitioner, that they realize that if we, the doctors, have referred them, we retain legal responsibility for the outcomes. So let us proceed to section 2, which covers clinical evidence on CAM and alternatives for menopause symptoms. Subsection 1 discusses the clinical evidence on plant-derived products used in the treatment of menopause symptoms. So phytoestrogens, these are plant substances or metabolites that induce biological responses, can mimic or modulate the actions of endogenous estrogens, and are known to have a selective estrogen receptor modulator type effect, so a SERM type effect. They're subdivided into flavonoids and non-flavonoids. Flavonoids are further subdivided into isoflavones, comestans, and prenylflavonoids, and non-flavonoids are comprised of lignans. Soy phytoestrogens are most commonly used as an alternative menopause hormone therapy for the treatment of menopause symptoms. And we should remember that phytoestrogens share the basic structure of other hormones. However, their potency is estimated to be about 1,000-fold weaker compared to 17-beta estradiol. This meta-analysis was conducted to examine the efficacy of phytoestrogens for the relief of menopause symptoms. The inclusion criteria for the analysis were RCTs, perimenopausal or postmenopausal women experiencing menopause symptoms, and interventions involving phytoestrogens taken orally. 15 RCTs were included in the final analysis. The results of the analysis are that 7 studies indicated no significant benefits with phytoestrogen on menopause symptoms as compared to placebo. And this was assessed by the Cooperman Index. 10 studies that reported frequency of hot flushes indicated reduced frequency with phytoestrogens compared to placebo. And 5 studies that reported side effects showed no difference between the 2 groups. A model-based meta-analysis was conducted to quantify the efficacy of soy isoflavones in the treatment of menopause hot flushes. 16 studies of soy isoflavones containing mean effect data of 65 placebo-treated and 66 soy isoflavone-treated groups, respectively, were included. And the study found that the maximal percentage change in hot flush reduction by soy isoflavones was 25% after elimination of the placebo effect, so a fairly modest effect. The maximal effect of soy was estimated to be achieved by 48 weeks of treatment, so thus there was a very slow and slight attenuation of menopause hot flushes compared with estradiol. Esequol has recently received attention for its ability to alleviate vasomotor symptoms in menopausal women. It is found only in trace amounts in very few foods and is produced in the body as an intestinal metabolite of the soy isoflavone daidzein. Not everyone can produce Esequol. Only about 50% of Asians and 25% of non-Asians host the intestinal bacteria that convert daidzein into Esequol. Clinical trials evaluating the effectiveness of Esequol have demonstrated improvements in VMS, but these trials were small in size and require confirmation. So overall, the data on estrogenic effects of soy are inconclusive. In theory, the isoflavones from soy behave like selective estrogen receptor modulators rather than 17-beta estradiol. However, women with a personal or strong family history of hormone-dependent cancers, such as breast, uterine, or ovarian, or thromboembolic or cardiovascular events, should be cautioned about the potential risks of soy-based therapies in these conditions. Black cohosh, I'm sure many of you have heard of, also referred to as Simicifuga racemosa, is a perennial plant native to eastern and central areas of the US. It contains flavonoids, and it is suggested to act as a partial agonist at the 5-HT opiate receptors, and may also have affinity for the dopamine receptor. A Cochrane review suggested that there is currently insufficient evidence to support the routine use of black cohosh for menopause symptoms. However, they did also conclude that there was adequate justification for conducting further studies in this area. The uncertain quantity and quality of trials highlights the need for improved reporting of study methods, particularly with regards to allocation, concealment, and the handling of incomplete outcome data. St. John's wort, another popularly used herb, is a perennial herb native to Europe. It is said that the Knights of St. John used to use the leaves from St. John's wort to staunch blood flow from their wounds because they were perforated. It contains flavonoids, and it's suggested to be used not only for the treatment of mild to moderate depression, but also for the treatment of menopause symptoms. A study comparing the effectiveness of St. John's wort and placebo suggested a significant improvement in menopause-specific quality of life and a significant reduction in sleep problems. No significant differences were observed in frequency or severity of hot flushes, however, between the groups, and they concluded that more research was required. We must also remember that St. John's wort interacts with many medicines and may weaken the effects of tamoxifen, a combined contraceptive pill, and HIV medications. Dong Quai is made from the root of Alpha sinensis and is a perennial aromatic herb native to China and Japan. It contains coumarins, polysaccharides, flavonoids, and vitamins and minerals, and has been used in traditional Chinese medicine for many years to regulate the menstrual cycle. However, it is not superior to placebo in managing menopause symptoms when used alone. There are some studies that show when it's combined with other herbs and soy that there can be a benefit. Again, Dong Quai may interact with warfarin and should be used with caution in this context. Other vitamins for the management of menopause symptoms or for the prevention of cancer and cardiovascular disease are not recommended for healthy non-deficient women, with the exception of folic acid to prevent neural tube defects and vitamin D supplements for older persons at risk of falling. This slide shows the final recommendation statement from the US Preventive Service Task Force on vitamin supplementation to indicate insufficient evidence to prevent cancer and cardiovascular disease with vitamins and minerals. This second subsection discusses the clinical evidence on complementary and alternative therapies practices in the treatment of menopause symptoms. Chu conducted a meta-analysis to assess the effects of acupuncture on frequency and severity of hot flushes, menopause-related symptoms, and quality of life in women in natural menopause. The final analysis included 12 studies and just under 870 participants. However, none of the studies included a sham control, and hence the placebo effect was not eliminated in any of the studies. The analysis did suggest a significant reduction in frequency and severity of hot flushes. However, in this subsequent study, which is probably the most robust for use of acupuncture in women with hot flushes, the study did include a sham treatment arm. And the study demonstrated that acupuncture was no more effective than sham treatment, suggesting that there is a strong placebo effect. So although uncontrolled studies suggest a benefit for acupuncture for the treatment of vasomotor symptoms, compared with sham therapy, no benefit of acupuncture has been seen, and further research is needed into the effects of acupuncture on vasomotor symptoms before it can be considered a more effective therapy than placebo. So let's look at the benefits of the different CAM techniques in relieving menopause symptoms. Regular aerobic exercise has been associated with a reduction in VMS. Not all RCTs support the case that regular yoga practice will reduce VMS, but meta-analyses are encouraging. CBT is effective at reducing VMS problem ratings, but not VMS frequency. Mindfulness-based stress reduction has demonstrated insignificant results in reduction of hot flush intensity. Paced respiration is unlikely to provide any benefit for hot flushes. So let's look at this systematic review and meta-analysis conducted by Kramer et al. On yoga. Several databases were screened for RCTs that compared the effectiveness of yoga on menopause symptoms to those of no treatment or active comparators. 13 RCTs with over 1,300 participants were included. The study findings were as follows. Yoga was found to be associated with a reduction in total menopause symptoms compared to no treatment. It had some effect on vasomotor symptoms compared to exercise as control. And the effects were robust against selection bias, but not against detection and attrition bias. The authors concluded that yoga seemed to be effective and safe in reducing menopause symptoms and that the effects were comparable to those achieved by other exercise interventions. Again, more data would be welcome. This study was conducted to evaluate the efficacy and feasibility of a guided internet-based CBT program by Mara Hunter's group. And they were looking at alleviating and reducing the severity of menopause symptoms in breast cancer survivors. It was a small study of 21 breast cancer survivors completing questionnaires at baseline and at 10 weeks. The primary outcomes of the study were compliance rates, participant and counselor satisfaction, and secondary outcomes included level of endocrine symptoms and hot flush, night sweat problem rating scales. The study findings were as follows. 78% of women reported sufficient progress and 83% reported feeling more control over their symptoms after completing the program. 89% of women were satisfied with the online modules and 94% were satisfied with the user-friendliness of the program. And 83% thought that the treatment was the correct approach for their symptoms. A larger randomized controlled trial is underway to assess the efficacy of this program. And in this final subsection, we'll just have a quick look at the clinical evidence on other complementary and alternative practices. So other approaches such as homeopathy, naturopathy, and Ayurvedic medicine may have an application, but the strength of the evidence is low. Some evidence suggests that homeopathic treatments are more effective than placebo. However, we need better quality data. Naturopathy methods, which employ an array of healing practices, including diet, hydrotherapy, spinal and soft tissue manipulation, and use of electric currents and ultrasound, have limited evidence to demonstrate the safety and efficacy of these modalities. And again, we need further evidence. And again, some evidence exists that Ayurvedic medicine is more effective than placebo. However, the strength of evidence is low. So in summary, ladies and gentlemen, dear colleagues, complementary and alternative medicine is a group of diverse medical and healthcare systems, practices and products that are not presently considered to be part of conventional medicine. There is global interest in CAM, especially soy-based products, because of the higher level of consumer awareness and also because of controversies around MHT and the need to find alternatives where conventional MHT is contraindicated. Although some studies show a positive effect of CAM in the management of menopause symptoms, larger and more methodological trials are required for CAM to inform society recommendations and guidelines. And balanced communication of evidence-based CAM options compared to conventional medicine is ultimately what is required. Thank you very much for bearing with my voice, which is slightly below par today. Thank you.
Congratulations, Nick, and congratulations on getting through that.
Thank
So
you.
now we're going to answer some questions and answers, and we hope to get a bit of a lively discussion. The whole webinar won't be more than an hour and 20 minutes. We might not need to go that long. Anyway, I hope we get some discussion between participants. So first of all, there's a question from Christina Toha. Is there any contraindication in using venlafaxine in women with hypertension? And I'll give this one to Sue.
So thank you, Wendy and Christina, for the question. Obviously, if anyone's got hypertension, the main thing is to treat the hypertension. And if a woman has treated hypertension, there's absolutely no reason not to cautiously introduce venlafaxine. But as for any medication, when we have polypharmacy, you always have to check that the treatment that you're introducing is not going to interact with any other medication the patient's on. But in general, it's not an issue. And again, we always cautiously introduce venlafaxine at 37.5 milligrams and then go up to a higher dose. And not all patients will tolerate it.
And then another one from Aud Belliar is for Sue. Is there any link between oxybutynin and Alzheimer's disease?
So I guess this is provoked by a study that was an observational study published last year. I think it was a Canadian study looking at using different treatments for urinary incontinence, comparing, I think it was oxybutynin and other compounds of that nature with beta-3 agonists. And the finding was that suggested that there might be a small increased risk of dementia in women or in people who started the oxybutynin type drugs, but it wasn't oxybutynin alone. I think that was only about 20% or 25% of the compounds looked at. And I think one has to be really cautious in interpreting this data. It wasn't compared to placebo, it was compared to beta-3 agonist medication. And there are so many variables that influence choice of drug, as well as the onset of dementia. And unless one does a randomized placebo-controlled trial, you can't draw any conclusions. And again, if I recall correctly, the evidence was suggestive that the main concern was effects in men rather than women. So no, it would not stop me prescribing it for patients.
How about you, Nick? Do you feel the same way?
Yeah, absolutely. But we need better data, as Sue said.
Okay, Nick, do you use black cohosh? And this is a question from Yair Frankel for both Sue and Nick. There was a recent webinar on the use of black cohosh, I believe, by the center at Yale, and they said that they use this for women with breast cancer. So Nick, do you use it? What's your experience? And then I'd like to ask Sue Davis.
So I don't personally use black cohosh, but I do occasionally recommend it. Yes, I mean, I think it has a reasonable evidence base. As the Cochrane review said, we would like even better evidence. And there is ongoing controversy as to whether black cohosh has an estrogen type effect or not. Our oncologists, our breast oncologists, are anxious about using it in breast cancer patients because of its potential estrogenic effect. So I tend not to use it in patients with hormone receptor positive tumors. However, I have seen benefits with it in patients who don't have that particular contraindication. I think it's important that if black cohosh is going to be used, that a good quality product is used, because as I'm sure you're aware, there have been links with liver toxicity and liver failure. But it seems that one of the reasons for that was that it was a poor quality black cohosh preparation which potentially had been contaminated with blue cohosh, because it grows in the same fields, which apparently is more hepatotoxic, and therefore a good quality product, which is guaranteed for quality and purity, should be safe.
How about you, Sue?
I don't prescribe it and I don't recommend it. I'm not going to tell somebody to stop taking it. I'm not convinced by the data. If you look at the studies of black cohosh that have shown any suggestions of efficacy, they're usually studies of women getting like 2 hot flushes a day. These are not studies that have been done with the rigor of studies recommended to be done by, say, NIH, FDA standards, where women are required to have a hot flush frequency of at least 50 flushes a week, etc., or 7 per day. And so the efficacy has been very weak in women with few vasomotor symptoms. And a lot of the studies have reported the Kupperman index as an outcome, which is a complete nonsense. The Kupperman index does not evaluate menopausal symptoms. The one attempt that was ever made to validate the Kupperman index couldn't even validate it. So I think the data is poor quality and not enough to make a recommendation on.
Yeah, I have to say for myself, if I've ever tried it in people, I haven't been bowled over by its success. So it's almost like we're desperate when we recommend it. So I don't know if it works much better than placebo. I guess there's been some trials also. Maybe it's minimally better, but not a whole lot. Next question by Sarah Ball to Sue. She's wondering about comments, whether it's useful to use the phrases absolute contraindications and relative contraindications. Most relative contraindications mentioned would be fine with body identical hormone therapy. And as informed choice is so crucial, is there anything absolute? And her concern is using these terms, adding to the fear of hormone therapy against people who prescribe.
I think there's a need for some guidance. I don't know if Sarah recognized that I did highlight in the relative contraindications that most of the relative contraindications were not contraindications to transdermal or body identical. And when we say body identical, I think we actually have to be specific, transdermal, not oral estradiol. So I don't consider gallbladder disease or cardiovascular risk features a absolute contraindication or a relative contraindication to non-oral estradiol. I think it would be a brave person that would prescribe estrogen to a postmenopausal woman with undiagnosed vaginal bleeding. I consider that absolute. I think that once you sort out the vaginal bleeding, you might want to give it, but I think that there are some things that we can be fairly clear on. Of course, breast cancer is never an absolute contraindication, but most of us would have 1 or 2 patients or maybe more who have had breast cancer who we have prescribed estrogen to, but in general, we would put that out as an absolute contraindication. I think if we start saying it's a relative contraindication, there's a potential to do more harm than good. So the number of absolute contraindications are very, very few. But I think there has to be practice guidance. And I think it makes people think before prescribing and also do health checks before prescribing. So I do stand again with what I've said.
How about you, Nick? Absolute and relative contraindications?
One of my old colleagues used to say that the only absolute contraindication is that the person is male or they don't want hormone therapy, but I suppose male isn't necessarily contraindication now either. Look, I think it's about taking these issues in the context of who you're prescribing for and what other options have been tried either successfully or unsuccessfully. And I think you can only talk about absolute and relative contraindications in the context of that individual. I don't buy the concept that we can talk about those in an abstract way. And I know that's not how the summary of product characteristics are written, but in our day-to-day practice, we will sometimes give hormone therapy to women with an estrogen receptor positive breast cancer because everything else has been tried and they don't have any quality of life. So I think let's think differently about this concept, and let's think of it in terms of individualizing rather than making absolute rules.
But Nick, would you give it to a woman with completely undiagnosed vaginal bleeding, or would you sort out her vaginal bleeding first? I mean,
no,
I
I'm
think
saying,
that,
Sue, that we, no, Sue, I'm saying it needs to be thought of in the context of our clinical practice. And of course,
yeah,
in terms of our clinical practice, we would not give, well, probably anything until we've diagnosed what the cause
exactly.
of that vaginal bleeding is. So accept it from that perspective. But again, it's taken in clinical context.
So I just want to point out that Stephanie Pickart's mentioned the review and meta-analysis on black cohosh by Camille Castello-Branco that was recently published in Climacteric and showed a significant effect of isopropranolic black cohosh extract for menopausal symptoms. And that's the one specifically, I think it was Mary Jane Merkin, also part of that crew, who did say that was the one they used at Yale. So I don't know, do you have any comment about that article, Nick? Or I've seen that article, so.
I think it's always what you leave in and what you exclude. Other meta-analyses have not shown benefit, and what you have to do is line up what studies were included and what were excluded from different meta-analyses. So when you get different meta-analyses giving you different results because they include or exclude different studies, you have to see that the effects are probably pretty line ball. In contrast, you wouldn't see meta-analyses of cholesterol lowering and cardiovascular events giving contradictory results, whether they included or excluded some studies, because it's a consistent finding. So I think it's a bit how you slice and dice it as to what you put in the meta-analysis for something like black cohosh.
I think, Wendy, it's difficult because what we're doing is we're applying standards that we apply to regulated pharmaceutical products that have gone through rigorous evaluation during their development to those of complementary therapies where the evidence isn't as good. And if you're doing a comparison between a CAM and conventional medicine in terms of data will almost always come out on top. But if you're doing a comparison with other complementary therapies where the data are not necessarily good either, then it becomes a different comparator. And as you said, Wendy, it really depends on what the situation is. If you've got a patient where they have very limited options for prescribing, and you've got reasonable, at least you have some evidence for efficacy and safety for a particular product, where it's unlikely you're going to do any harm, then it's not unreasonable, I think, to say to the patient, well, you can try it and see if it does have some benefit. But let's not focus too much on just black cohosh, because there are other preparations out there that we recommend that are derived from isoflavones, for instance, such as red clover isoflavones. There's the fermented soy preparation. There's Femal, which is derived from pollen extract. So, there are various options, and usually what you're doing is working your way through it through a discussion with the patient to see what they would feel most comfortable trying next, and also taking into account pharmacological options, as Sue has discussed, and hormone therapy as well in your overall discussion.
Right, so as to that, I think you mentioned them. What about red clover? What about GC fem? That's pollen pistils. Do you have any experience with that? And what about red clover?
Red clover has
So,
been studied in really good quality studies and shown to be no better than placebo. Look, I agree with Nick and I disagree with Nick. I agree that the patient, obviously, I mean, everything I say is in the context of the patient having a discussion with the patient and the patient's choice. But having said that, I think there's a big difference between us discussing with the patient and working through a list of things that they might choose to try, as opposed to recommending things with the expectation that they're going to be benefit. So I think how we explain these options to patients are important, and not getting up false hopes, and also not and looking at the cost to the patient of trying a lot of different things that are going to be no benefit to them. So I think there are many things to consider. But if there's studies like the red clover that's been shown in quality trials not to be better than placebo, it's very hard to recommend that as a treatment option.
Yeah, I
the
had my own personal experience with that. When I worked in the States, a woman came and told me she had bought this great product in the pharmacy and it worked amazing for her hot flashes. So I said, would you mind bringing me that? So she brought me a bottle and I checked the ingredients and it had mashed up pig ovary. So
that is a great segue into what I was going to say next, which was that one of the problems that we have is we can't do direct comparisons and proper meta-analyses because each one of the products has different constituents. And so you end up not necessarily comparing like with like. Yeah, absolutely. You have to be very cautious about the purity of products. And of course, always thinking about the placebo effect as well, which, placebo works to a certain extent. So we mustn't get away from that. Now, there are some data to suggest that some isoflavone preparations can have some efficacy, and when we reviewed those when we were drawing up the NICE UK guidelines. There is an RCT also for the pollen extract as well. Now, these data obviously need to be corroborated and backed up, but there are some products out there that are evidence-free, let's say. So I think we should at least prescribe products where people have actually tried to do some research into them. And also particularly important is making sure that they are good quality products. Because as Professor Edzard Ernst said from Peninsula University, if something has an effect, it can potentially have a side effect. And just because something is alternative does not necessarily mean that it's safe. So first do no harm, as in the Hippocratic Oath, and then hopefully get some benefit.
Yeah, I also talk about the patients who come with their shopping bags full of products and they've spent a lot of money at the pharmacy before they actually seek medical care. So in conclusion, let's say, how would you start and what would be your first treatment for vasomotor symptoms?
For me, for women who, in general practice, and I'm talking about prescription therapy, because by the time I've seen the patients in our system, they've probably tried a lot of the over-counter stuff. If they're not on tamoxifen, I would generally recommend low-dose paroxetine, basically because it has been shown and FDA approved for the treatment of vasomotor symptoms. I find that more women get adverse effects even with low-dose venlafaxine, and I've generally found that my starting point would be a low dose of paroxetine. In women with breast cancer on tamoxifen, I would not use that. I would use it in women on aromatase inhibitors. And so in that instance, I'd use gabapentin, although more recently I've had a lot of success with oxybutynin. And I talk to patients, of course, about not just layering clothes, but women who are carrying excess weight. We know that's a risk factor for vasomotor symptoms, healthy lifestyle, identifying triggers, the usual things.
How about
So
you,
yeah, I
Nick?
agree with Sue that, you know, whatever we recommend, it should be underpinned by lifestyle, diet, exercise, minimizing alcohol, stopping smoking, etc. And then I give women the choice as to whether they want to go down the complementary route or whether they want to start with pharmacological options. And just to talk about pharmacological options, I do offer venlafaxine as one of my first options. Gabapentin has become a controlled drug in the UK. It's more difficult to prescribe it now, but I think the data with oxybutynin look encouraging. And if you use the modified release variety, 5 or 10 milligrams, then I think it's reasonably well tolerated. I think the neurokinin receptor antagonist, which I know we're not really addressing today, showing a 70 to 80% reduction in symptoms, are going to be a genuine alternative to hormone therapy. We're about to start a phase 3 clinical trial with one of those at the moment. In terms of the complementary therapies, I'm trying to avoid completely an estrogenic effect, I've seen some reasonably good outcomes with the pollen extract preparation. But if a phytoestrogen is not contraindicated, then potentially one could try a red clover isoflavone or a soy isoflavone product. Again, very mixed results with those, which is indicated by the data. But the soy isoflavone product, one of them does have an RCT sort of backing it in terms of clinical efficacy compared to HRT. And then I think we mustn't forget that yoga and CBT are showing some good outcomes in terms of the studies that have been done recently. We need better quality data, but some of the work that Myra Hunter's doing in the UK, for instance, with CBT in breast cancer patients has yielded very good results. So I think those are options that should also be offered. The difficulty in the UK, and I don't know about where you guys are, is accessing CBT and other speaking therapies is actually very difficult, and people often have to go private.
Okay. Sometimes I'll use gabapentin specifically at bedtime for patients who have more night flashes, and those are the ones that bother them the most, as gabapentin is one of its biggest side effects is somnolence, or even people where sleeping is the most prominent part. And then can one of you comment about how you would start? What's the starting dose of gabapentin?
I start at 300 milligrams at night and increase it accordingly. I've had patients I've seen recently who are taking it during the day and they're completely knocked out.
Right.
And we do need to advise patients that they can be quite somnolent from it. The other thing we should comment on too, although we're talking about vasomotor symptoms, and thinking about the sort of absolute contraindications, in my mind, there are no absolute contraindications to using vaginal estrogen in women. And although women will often present with the hot flushes and the issues, we must remember to treat the other aspects, and particularly vulvovaginal atrophy symptoms. So estrogen's not absolutely contraindicated across the board in terms of how we might give it.
Nick, there's a few questions about.
I just wanted to say I totally agree with Sue in terms of the starting dose of 300 at night, and that it can help with sleep. But if there are mood symptoms, then I would tend to go more for a sort of antidepressant. I think it's about individualizing it according to that person's particular symptoms. We mustn't forget that VVA symptoms are particularly distressing in patients who are on tamoxifen and aromatase inhibitors. And in collaboration with the breast teams, that it may still be an option to use estrogen, particularly where tamoxifen is used and the estrogen receptors are being blocked and there's no significant systemic effect. But there are also very good quality moisturizers now, which should be pH and osmolality balanced, as per our paper in Climacteric with David Edwards.
So apropos of that, Nick, would you use isoflavones or other soy products, or even red clover in patients who had breast cancer?
Well, I would be more cautious, and I wouldn't use them as a first line in breast cancer patients. But again, if we were sort of running out of options, then cautioning that yes, they tend to have a SERM type effect. They tend to go more for the beta than the alpha estrogen receptors in the breast. But we know from some studies that you use too high a dose of isoflavones, potentially there's overspill from the beta into the alpha receptors. So I would be cautious. But there is a study by Trevor Powles from the Royal Marsden that showed that in women with a family history of breast cancer or other risk factors, but not necessarily having had it before, that there didn't seem to be an excess risk in those groups.
Wasn't there also a Chinese study looking at soy products in breast cancer survivors showing no effect on survival?
Yeah,
So,
I mean, as I say, it's this.
Yeah.
It's
okay.
this potential SERM type effect.
So there's a question from Manju Navani. Can sertraline or citalopram be given to breast cancer patients on tamoxifen?
The studies of sertraline and citalopram have been in patients with breast cancer. And so this, they can be given.
Yeah, it's the fluoxetine and paroxetine, which one has to be cautious about.
And particularly paroxetine.
Yeah.
I'm not sure. This is a question. From Jayotsna Singh, can morning after pills cause hormone crash or severe hormonal imbalance during menopause years?
I don't think it's a black and white answer to that one at all. I don't know how to interpret it.
I'm presuming they're referring to progestogenic adverse side effects, which can be CNS, can be androgenic, and can be mineralocorticoid. So yes, the POP can cause, but again, are we talking about progestogen only? Are we talking about the combined method? I'm not sure what the context of this question is.
From R. Muharram, is there any issue for using menopausal hormone therapy during COVID?
I think that's probably beyond the scope of this conversation. I mean, we could sit here and talk about it for quite a while.
Okay. And if anybody had, this is for Dr. Panay, Professor Panay, what's your opinion on using resveratrol containing supplements and its impact on vasomotor symptoms? And is it possible to use in women with breast cancer risk?
So I don't have great experience of using resveratrol in the context of alleviating vasomotor symptoms. And I'm not aware that there are particularly good data regarding that, but we know that it can be good from a cardiovascular preventive perspective. So I don't have any objection to it being used, but as I say, I can't back it up with data to say that it can help for menopause symptoms per se.
Although I'd be cautious about the cardiovascular data. A lot of the papers were retracted because some of it was fabricated data.
What would you recommend for those late hot flashes that occur in older people in their 70s or 80s who don't have hepatic or renal failure? We see these start again. I think the etiology is different.
This is an area we really don't understand, and we've recently published that women over the age of 70 basically have estrogen and testosterone concentrations similar to young women. And I don't think we really understand sex steroids in elderly women at all. And there is definitely a group of women that get a resurgence of vasomotor symptoms in their, seventh, eighth, and ninth decades. We don't really understand it. And I think how you choose to treat these will depend on the severity. And I would say that there are several women who have been hysterectomized I have treated with extremely judicious doses of transdermal estradiol in that age group, because their symptoms have been so diabolical that they have been happy to make that choice themselves. So I think there's age to me is not an absolute contraindication, irrespective of what WHI showed. And I think these are very difficult patients to treat because their symptoms can be just ghastly.
Yeah, I agree with Sue. And like her, I would offer as an option a low-dose transdermal preparation for alleviating those symptoms. Sure, I mean, if you're suspecting something else like a pheochromocytoma or whatever, then you do those investigations. But in my experience, I have patients who basically have come off or been told to come off their HRT. They've been getting symptoms for years and putting up with them, and they're sick to the back teeth because of their symptoms and come to you, for help. I want to restart my hormone therapy. And if you've established that, that's what should be done, as opposed to trying, a pollen or an isoflavone preparation in the first line, then low-dose transdermal, a 25 microgram patch. Sometimes you might even get a benefit from cutting a 25 in half and using 12.5 micrograms. And so obviously you've got to target it according to the particular risk factors apart from age in that individual.
Yeah, I think it's really difficult. And it's amazing. Sometimes people get away with a very low dose, even twice a week, and that's all they need. But I'm not sure about the etiology of these, whether they're more vascular in older women. I agree with you, Sue. We need more data on women who are older and longer term users, like the Olympic users. And I also think that people should have the right to choose. There are so many other medications that people take that are so much riskier than a little tiny bit of hormone therapy. But why are we so almost misogynistic about denying people the benefit when they make the choice? I don't understand the philosophy behind this. We won't get into that today.
Yeah. Well, I think it's important to say that 5 to 10% of women will have symptoms indefinitely. And the guidelines from IMS, as for other societies, is not that we should put arbitrary limits on duration of use. Yes, there should be an annual reevaluation of pros and cons of continuing the hormone therapy. But in my view, if they've got symptoms and they don't have other contraindications, they should be allowed to continue indefinitely.
Right, I would agree.
Yeah, and we now know also there's actually a genetic difference in people that have severe flashes. I think it's a tachykinin change that's been shown. So there may be a genetic reason why some women continue to have them. So let's see. I think we've sort of answered some of these. Any experience or evidence with piasclenidine? I've never heard of it. PIASCLEDINE. That's from Claire Hui Hong Tan.
No.
Oh, and here's another one. Any experience with cannabis? We just did a systematic review of looking at information on the effects of cannabis on vasomotor symptoms. There is no good prospective randomized control trial specifically for treatment of vasomotor symptoms. Do you want to comment, Sue or Nick?
I think we don't have enough data. I don't think we have enough. I think it's something worth looking at. And again, it's going to vary with the doses, whether it's oral, whether it's transdermal, etc. you know, whether it's CBD or THC or I don't know. I think we need more data.
I think it's really interesting, and you know, we should do a study. I know that just anecdotally, some patients have had benefit, but as with Sue, we need to do proper research with it.
Okay, from Christina Toha again, Dr. Panay, how long does it take CBT to have an effect on treated patients?
I mean, you know, the programs that Myra Hunter and co have been instigating have usually been a series of 6 to 8 sessions, and it's an ongoing thing as well. It may be that top-up sessions are required. I mean, as with any intervention, there may well be benefit after 1 or 2 sessions, but it's about ensuring that that those benefits are maintained, and that's where sort of longer term support may be required.
And from Ingrid Pinas, any experience with the oxybutynin patch?
I've used the tablets in patients, not patches.
Nick?
No, only tablets.
And Sharon Shakur, is BMI over 40 a contraindication to HRT?
For me, no.
Well,
but I would agree with Nick in, we often answer the question slightly differently, but I think we mostly agree. But my point with this would be, whether it be breast cancer or cardiac disease or whatever it is, don't make the patient the meat in the sandwich. So I had a patient like this the other day, cardiovascular disease, high risk, but before I provided the patient with a complete recommendation, I spoke to a cardiologist. So she didn't go back to the cardiologist and have them throw their hands in the air and say, that's outrageous, you can't take it. So I think you need to consult with other colleagues caring for the patient with the patient's permission before making a directive.
Yeah, I totally agree with Sue. It's about individualizing, looking at the other risk factors, severity of symptoms. I think the key message really is, if you are going to prescribe, go low dose, go transdermal, use a non-androgenic progestin like micronized progesterone or dydrogesterone to minimize potential risks.
Do you think that hormones work the same in women who have an elevated BMI over 40? That the estrogens are sequestered? And do you have any comment about needing higher doses? You mentioned lower doses in terms of efficacy, Sue?
I think that we can't look at hormones unidimensionally. So a woman might have a high BMI, but she might actually have highly sensitive nuclear receptors, so the estrogen action could be very efficacious in her. I've seen women with low BMIs who need big doses. So I think that, and in particularly transdermal, we get fixated on dose, but you could give some people, you give a 25 microgram patch to and they get a higher blood estradiol level than a woman you give 100 patch to. So it's skin absorption, it's how it acts in the cell. It's the whole box and dice for each woman. So that's why we individualize. And so you can't just, about the only thing I think you can generalize with is that heavy smokers tend to metabolize estrogen more rapidly. But apart from that, fat women, thin women, square women, round women, we can't predict.
And has anybody had experience with stellate ganglion blockade? Trudy Smith?
I tried to organise it for a couple of patients, and you need an expert anaesthetist. And if you don't have that, you can't do it, and I couldn't find one. So Nick may have had experience.
Again, I've organised it with our neurosurgeons on a couple of occasions for sweating, and it has been of benefit. I know that Pauline Mackey, Lee Shawman have done quite a bit of work in this area and have shown a benefit. But you know, it's quite an invasive procedure, so it's not the sort of thing that you would recommend unless pretty much every other option has been exhausted. And in fact, Botox is actually reasonably good for sweating as well. So, and that's easier to administer.
Yeah, I have used it. I organized, we have an anesthesiologist at our hospital, and I think the success rate is about 50-50, maybe a little higher. I had one woman who was absolutely desperate and it worked for her, and another one that it didn't. So I agree. Just Jayotsna Singh says that her plan B, she means progesterone only. Are there any contraindications for phytoestrogens and soya? Nick?
I think I mentioned in my presentation that we need to be cautious in conditions where estrogen generally would be contraindicated. Those are the main ones, you know, hormone receptor positive malignancy, venous thromboembolism, et cetera, et cetera.
So the person who wrote that PIASCLEDINE is a mixture of soya and avocado oil and is being given to ease osteoarthritis, but they hadn't heard it's used for vasomotor symptoms. I don't think we know much about it either. What about promestrine local for women with breast cancer, PROMESTRIENE?
No idea.
I don't have experience of using promestrine.
Okay. I think we covered about stopping hormone therapy after 5 years. We don't necessarily recommend that if someone's still having symptoms. In someone with increased familial risk of breast cancer, would you prescribe testosterone with an aromatase inhibitor, or would you categorically not prescribe testosterone for symptoms of lack of energy and fatigue, no vasomotor symptoms? Suzanne Hooper. Sue.
So there is absolutely no evidence to use testosterone for lack of energy and fatigue. These are really common symptoms in women, women of all ages really, but particularly in postmenopausal women. And I'd be trying to work out why that person has lack of energy and fatigue. You know, do they have underlying thyroid disease or iron deficiency, or simply stress or poor sleep? But testosterone is not a tonic for those symptoms. I know that there is a trend for some people to recommend testosterone with an aromatase inhibitor as pellets to prevent breast cancer. There is no evidence that that is effective or safe or appropriate. And so testosterone should not be used to prevent breast cancer. So the only evidence for the use of testosterone in a woman is for the treatment of low sexual desire with associated distress. Of course, we need more research, but I think that we should prescribe on the basis of what we know, not what may be placebo effects.
I just think maybe one of the last questions by Myra Hunter about CBT for vasomotor symptoms. You can get a help book online, and it says, I think by Cheryl Green, there's one on the internet that you can order. And she said, thank you, 4 to 6 sessions delivered effectively in self-help book format, group online, and by trained nurses too. So we have used that as well. We had a group here too. So I'd just like to thank my colleagues, Susan Davis and Nick Panay, for your expertise and your time. And I'd like to thank IMS for sponsoring this wonderful webinar.